Good afternoon, everyone. Today's topic is traumatic brain injury and steroid, an evidence-based review. This steroid has been shown to have potential neuroprotective effect after traumatic brain injury. Corticosteroid, anabolic steroid, no. Hmm. No benefit, no harm. Anabolic, no benefit, no harm. So it should be progesterone. Next question is, what was the key finding of Cochrane review regarding corticosteroid use in traumatic brain injury? 4 options. Whether it significantly reduced brain swelling or it had no effect on patient outcomes. It increased the risk of mortality. तो ये सही आंसर है. Cochrane review after crash trial आया था. Which of the following neurosteroid showed increased levels in the brain following traumatic brain injury, suggesting a neuroprotective role? Either testosterone, estradiol, pregnenolone, or corticosteroid. Answer is pregnenolone. Pregnenolone is a precursor of progesterone, and being neurosteroid, the concept is it should be secreted in the brain and then converted into progesterone. Which hormone has been linked to worse outcome in traumatic brain injury due to its increased level post-injury? Either estradiol, whether progesterone, dihydrotestosterone, or cortisol. The answer is estradiol. What was the conclusion of the study on anabolic steroids and traumatic brain injury? Whether steroids significantly worsened brain injury, had no effect, improved cognitive recovery, or reduced inflammation. Okay, no effect. In delayed cerebral edema after traumatic brain injury, which steroid was found to be beneficial? Testosterone, dexamethasone, aldosterone, or cortisol? Delayed cerebral edema, dexamethasone. Which of the following mechanism is associated with neuroprotection by sex steroids in traumatic brain injury? Mechanism. How it protects? Either increasing inflammation would not be the answer. Reducing brain edema and improving blood brain function is the answer. So progesterone helps by reducing brain edema and improving blood brain function. Which steroid has been investigated for its role in preventing post-traumatic brain injury vasogenic edema? Traumatic brain injury usually have two types of edema. One is cytotoxic edema and second is vasogenic edema. Cytotoxic is because the tissues are damaged, so that edema is, you can't do anything with that. The remaining penumbra, circular part circumferentially present, have vasogenic edema. So which steroid has been investigated for it is no, dexamethasone. Dr. Prasad's paper, Manipal study, is basically focusing on vasogenic edema, not in acute cases, post-traumatic brain injury patient. So with this, so now I'll be talking on neuroprotective effects of steroid, which I have discussed before Shilpi's arrival. In 2009, it was an animal study by Harson where they found that sex steroids, inclusive of progesterone and estrogen, aided neuroprotection by the mechanism we have discussed, and it showed that progesterone treatment post-traumatic brain injury reduces swelling and maintains the blood-brain integrity. In a study by Gray where they have just looked into the levels of hormones, and they found that it increased these two levels, progesterone and estradiol, both levels are increased post TBI. So they thought might be it is neuroprotective or helping in recovery, which was later proved to be wrong. About corticosteroids in traumatic brain injury, we have discussed the CRASH trial, and this meta-analysis by Cochrane group has shown that corticosteroids do not provide any benefit in traumatic brain injury. Rather, they increased mortality in traumatic brain injury. But the second paper by L.G. Prasad, a neurosurgeon from Manipal, what he showed is if you introduce the steroid not in acute phase, rather in some as subacute phase, in doses where he described it to be 12 milligram per day and duration should be only 5 days duration of steroid. It helped in patients who are having delayed cerebral edema on 6th day of traumatic brain injury. This has led many a neurosurgeon to change their practice, and they changed it for the wrong because now they are introducing in the acute traumatic brain injury even on day one, which was proved way back in 2005 that it is not beneficial at all. So for our practice, we must be evidence based, we must not introduce it in acute phase. Anabolic steroid, they found no role. Anabolic steroids profiling have found no role. These two papers by Mills and Tabor have shown that it it may harm if introduced in rats. So I would say it's no benefit of anabolic steroid. About endogenous steroid changes, studies in animal models have shown that traumatic brain injury alters these steroid level and hence the recovery, and increased levels of pregnenolone and dihydroprogesterone. Pregnenolone is a precursor to progesterone. It may contribute to neuroprotection. So Mafry was the first to show, that too in animal studies, that progesterone or its precursor have some role in neuroprotection. But about Racolia study, it is contrasting to my first paper, where it showed that the level of estradiol and progesterone both have risen and they were protected. But this animal study show that there is no protection, rather it is harming. So estradiol is taken out of the protection list, and now remaining is only progesterone and the precursor pregnenolone. This, if you see what are their functions, so pregnenolone is a precursor, we know it. It enhances memory and neuroprotection. Progesterone, we know that it reduces brain swelling, protects neuron, and supports myelination. So this progesterone's, this ability to support myelination or help myelination is being utilized in osmotic demyelination syndrome, where you have infused sodium at a faster rate and overcorrected sodium level. That time you need to myelinate. So these progesterone is found to be beneficial in such ODS syndrome. Allopregnanolone is just a version of pregnenolone, and as I have discussed that it's a modulator of GABA A receptors, so it reduces anxiety and stress. So there is some FDA approved molecule with the name of bromhexol, which is actually allopregnanolone derivative for postpartum depression. Dehydroepiandrosterone, DEA, how it helps is it improves mood regulation, neuroplasticity, and estradiol, though it supports cognitive function, but levels, if it is high, they worsen brain injury outcomes. So now we can say that levels, if they are altered, if you are monitoring and checking levels in post-traumatic brain injury, and if they are altered, and if they are not in the ratio it has to be, everything is harmful. So coming back from all the studies, if the take home message from my side would be, people have tried looking at different hormones and associate it with better and worst outcomes both. My take would be the balance between the hormones should be appropriate. Any hormone in excess is not good for us, so it may not benefit anyone. Physiologically, it has to be in ratio. So if you have labs where you can do levels in possibly traumatic brain injury post 5-6 days, then it's not the single level or their relative increase or decrease, rather they're the proportion of all the hormones together, because we are balanced with that. So it has to be that way physiologically, because people will try to experiment, but basis should be this, rather than formulating a wrong hypothesis and doing a research. This is the crash emblem. It was corticosteroid randomization after significant head injury, meaning moderate to severe head injury, not mild. Corticosteroid, it's a randomized trial. About 10,000 patients were enrolled, and they were enrolled quite early, within 8 hours of injury. So it is seemingly a good study. And what outcome they measured were primary outcome death within 2 weeks of injury, and secondary outcome disability, adverse event, and long-term functional recovery. And what was the key finding? Key finding was negative. Corticosteroid increased the risk of death. Mortality rate was 21.1% in the steroid versus placebos, which is 17.9. And this resulted in a relative risk increase of 18% for death with steroid use. So it is harming rather than benefiting. If you are introducing steroid acutely within 8 hours of trauma, you are harming. And the reason behind maybe it is linked with higher infection rate corticosteroids. Conclusion was corticosteroid should not be used in the treatment of acute TBI. It was the strongest evidence with 10,000 patients. And following this, guidelines were made based on this, discouraging the use of corticosteroid. Impact of this trial is, since it was the largest good trial, that majority of the world shifted with no use of corticosteroid after traumatic brain injury. And it is good because we are now not introducing any harm because of medicine. This was the trial by LG Prasad from Manipal group in 21, where the objective was to evaluate the effectiveness of steroids in treating delayed cerebral edema, which is of vasogenic origin rather than cytotoxic origin, and that too in patients with mild to moderate traumatic brain injury, not the severest of brain injury. And unlike previous studies that used high dose of corticosteroid, he introduced to the lesser dose. And it was very small population, 9 patients, 6 males and 3 females with mild to moderate TBI, and dose was only 12 milligram per day, that too for only 5 to 7 days, and mean time to steroid administration was 7 days, and mean duration actually in days is 6.3 days. So you introduce it late, run it late, a shorter duration with a shorter dose, and there was symptomatic improvement, time to symptom resolution, and there was no steroid related complications since you have used the lesser dose for lesser duration. So the key findings were it showed complete symptomatic improvement of vasogenic edema. Mean time to resolution was 3 to 4 days, and there was no complication with steroid. So it suggested that steroid may be beneficial for delayed cerebral edema in mild to moderate TBI, but it needs to be introduced late. It needs to be introduced in smaller dose and to be continued for fewer days rather than unlimited. This was a tabulated version of CRASH. I discussed about corticosteroid harming the patient. The PROTECT trial, which came in 2014, which was stopped in between because there was no benefit associated. It was large RCT of about 882 patients, and the patient group were moderate to severe like in CRASH, but there was no improvement with the progesterone infusion. So it was concluded that progesterone is not effective. Dr. Prasad's trial was a retrospective analysis, weaker evidence. So maybe it needs further trial to confirm this. So key takeaways is these three trials which were done on humans on in traumatic brain injury patients. Crash trial showed that no corticosteroid in acute phase. Protect True trial doesn't show any benefit of progesterone supplementation in traumatic brain injury. Both Crash and Protect 3 were moderate to severe TBI. Dr. Prasad's trial was only, which was done on mild to moderate, and there the steroid was on lesser dose with the introduction, late introduction, and given for shorter duration of time. So, final slide would be steroid not to be used in acute TBI. Progesterone, though it was promising, but the trial built was not appropriate to show the result because it was given inadvertently to all the patient rather than those where the progesterone levels are low. So the trial was not good enough to quantify the change. Hence, it still remains one of the options for future studies. And Dr. Prasad's trial helped us to know that if you introduce DEXA in lesser dose and after 6 days for lesser duration of time, it may benefit your vasogenic edema because of trauma. So with this, I'll end. Thank you.